So we'll come to surgical approaches to macular holes. This is not an uncommon thing to happen in aging, as well as also trauma. Trauma is a cause, but people do come with macular holes, and it's important to understand that they have management which is mostly surgery. Ocriplasmin I just mentioned, it was talked about by Dr. Ajay Arora. Ocriplasmin may work only in the holes which are very tiny, like less than 250 microns. That's what the MAVI trial showed. And besides the side effects of ocriplasmin and the costs involved. So usually what they say is the first stage you give ocriplasmin, then post the patient for surgery. So that's an additional cost of about 40,000 or maybe 50,000 rupees, and the side effects of having a central vision disturbance like rod disturbance or even a subluxation of the lens. So when it's a hole formation, there's usually, it goes through the sequence of stages that you have a vitromacular traction, and that pulls off and causes a tear in stage 2, and then finally leads to a small hole less than 400 microns or a large hole which is greater than 400 microns. The biggest problem is to address the holes which are large. So this is this is just to show you the OCT. That it's important to study the interface to see the hyaloid, how it's attached to the one edge of the operculum, and it's created a operculated hole which is a stage 2 hole with some cystic changes. You can see the RP is disrupted, the ISOS is disrupted. So all these are not lines, now they are classified as bands, because line is a one-dimensional structure while this is a two-dimensional. So the new classification for OCT, these various ISOS, ELMs should be classified as bands, should be known as bands. So I just tell you what macular hole index is, and you can get a closure if you've done a proper surgery, and you can get 3 types of closure: the U, which is the best type of closure, the V form, or you can get a W form, which is a bare RP. Where there's a bare RP, it's a type 2 closure. So the U and V are basically type 1 closures. So you can study the bands also, because they affect the visual acuity outcomes besides the anatomical closure of the holes. These bands tell you about the visual outcomes, how they are. You do get to see the bands become continuous from discontinuous bands. So the study of the OCT is extremely important in macular holes, or for that matter, as Dr. Mallika showed very nicely, OCT plays a major role for all macular pathologies. So hole dimensions are very important. The two most important are the least hole diameter, which is actually more than 400 or less than 400, which is described as in the international literature. Larger holes are more than 400. And the MHI is the macular hole index, which is the base and the height, the maximum height divided by the base. If that's more than 0.5, as per the article first which came out in the American Journal of Ophthalmology in 2004, has better visual outcomes, while low MHI less than 0.5 have poorer visual outcomes. And as you can well imagine, it's the larger holes which have low MHI, less than 0.5. So we did a study here which was published in the recent issue of the Indian Journal of Ophthalmology, and at this stage I'd like to stop and acknowledge the work of Dr. Varun Gogia in this paper. He is a very upcoming and extremely hardworking and very professionally competent vitreoretinal specialist who was at RP Center and now works at Medanta Eye Hospital. And he did a lot of work about this various studies which we did. So we found that the most important thing in this study was the size of the ILM peel, which when it was greater than 2 disc diameter, showed a statistically significant closure with a p-value more than equal to 0.04, as compared to the other parameters, variables which were studied, which didn't show any statistical significance, including the hole index, macular hole index, and gases, the types of holes, and even the duration of the holes didn't play. So this played a major role. And dyes and drugs, just a brief mention. The newer dyes, infracyanin green, which doesn't have iodine, unlike the indocyanin green, which is very toxic, it eliminates the sodium from the solvent, which decreases retinal toxicity. Of course, brilliant blue G dye is now available. It's a very effective ILM stain, and thankfully so from Madurai, Aravind Eye Hospital, we have this dye available at very reasonable cost. And so we did this study again. This study was also done with me and Varun together, and we did a lot of work. And I feel that this person is doing excellent work. So it just showed that basically ILM peeling with brilliant blue G staining had a marked advantage or marked enhanced vitreoretinal interface. It's a relatively very non-toxic dye. Now, why do we do surgery? We're coming to the main, towards the part of the surgical aspect, that you mobilize the holes, remove the traction, activate the glial cells by doing the peeling, and also immobilize and oppose the holes. They slip together, the edges slip together by the gas and the face down positioning. So the larger holes, more than 400 microns, are the ones to worry about. We initially did a work of tapping of macular holes in which we increased the intraoperative vertical height so as to improve increase the macular hole index. So once the height goes up, the ratio would go towards the side of a higher macular hole index and better closure intraoperatively. So this study was done along with Sana Tinwala, who was also a senior resident at our place. She did extensive work with us, and she's now, of course, gone back to her hometown in Mumbai. She was at RP Center for 6 years, and we published this in the Asia Pacific Journal of Ophthalmology and also read it at the Hong Kong APVRS meeting. We found that this helped in the closure, and just a small video of what we do. Brilliant Blue G is squirted under fluid. You don't need to do it under air like Trypan Blue. And so after the peeling, which you use a disposable ILM forceps, in holes it's generally better to peel a larger area of ILM. And this is how we are raising the height of the hole so as to increase the intraoperative height of the macular hole index, the value more than 0.5. For larger holes, the values are usually less, or flat holes, because the flat holes don't have a good height. So we'll go on further. Now the latest is, of course, the inverted flap technique for large macular holes, which generally fail. And this landmark work was done and published in Ophthalmology 2010, and which showed that the inverted flap technique prevented the postoperative type 2 closure, which is a flat open with a bare RP in the center. And it showed both the functional and the anatomical outcomes improved for larger holes. And of course, the OCT was the one to diagnose the improved visual anatomy as well as the functional, depending on the bands. So this is just to show you a video of how we do it. So we do it very often now at our place, and we put this first flap right across. It's lightly blue stained. The Brilliant Blue doesn't stain it dark blue. It's generally so all around close to the hole to prevent the flaps from being lost or torn off from the edge of the hole. We tend to bring all the edges close to the ILM, close to the hole together, and then we trim off a couple of those flaps so as the remaining flap then comes over it. Now you could use a Tanos to put it over it, and then ensure that you keep it over it by doing an immediate fluid air exchange. And once you've done a fluid air exchange, it stays there, and you can put a little gas. Generally, this flap acts as a matrix, or you can see a surface tension effect, like a scotch tape effect, and it closes the hole quite effectively. And usually get a type 1 closure, which is what we want, and the vision generally improves well. And we've got very encouraging results with this. This is another patient who did very well, and it was a large hole, and you can see the flap, the redundant ILM flap which is there. This doesn't interfere with vision, that's what we feel, and you get a type 1 closure. So we're still following up our cases, and we've sent this for publication, and so we've decreased the prone positioning time, which was very arduous and painful for the patient, and we generally don't position him more than 3 days stick positioning, more than even 48 to 72 hour positioning. And towards just the end, I just want to say that I'd like to ask you an audience response question. ILM is a structural boundary between the retina and the vitreous. Why do we peel ILM in macular hole surgery? There's a lot of controversy, as Dr. Manga Dogra said. In diabetic macular edema, he says there is thinning, and I totally agree. But in macular hole surgery, it's important because the contractile elements. So I want to ask you, is the main reason is to ensure thorough removal of any tangential traction components, epiretinal membrane and associated glial cells? Is that the answer, or is it promote glial repair by inducing local expression of growth factors? Is that the answer, or is it the third answer that it reduces the possibility of reopening of surgically closed holes, or it causes a failure of hole closure by removal of a potential scaffold for reproliferation of myofibroblasts? So it reduces the possibility of reopening of the holes by removing the scaffold for reproliferation of these myofibroblasts on the ILM. Do you think all one, A, B or C, which is the correct answer? We don't have the handheld device which can actually give us a bar diagram to to show what is the response. So we can just by the show of hands, we can ask for A as the answer is A. Okay, if the answer is B. Okay, if C is the answer. And if D, which is all of the above, is the answer. So I think the maximum response is from the last, and that's actually the correct answer. It's all of the three above which are shown there, and D is the correct answer as the audience response questions. So I feel that you actually totally understood what we are trying to tell you in this instruction course. So we'll go on to the last speaker, which is Dr. Sangeeta Roy.